this has been the boost to my endoscopic knowledge and the addition to my armamentarium in terms of intraventricular endoscopy. So without further ado, I'm going to be moving forward with the presentation. And this would, just a brief introduction. As we all know, we have a lot of literature and sort of publications talking about the hot topic in this area of endoscopic third ventriculostomy. As
Mike, more, the sound is not well clear.
Ma'am?
Please make your mic is more clear.
More clear, yes. Okay, okay. Is it clear now?
Yes, it's clear to me.
Okay, okay. So I'm going to move forward. So we can see a lot of publications about endoscopic third ventriculostomy becoming a valid and durable treatment option for obstructive hydrocephalus. And this offers the advantages of the shunt independence with, this is a very interesting and inviting or motivating advantage to pursue endoscopic third ventriculostomy as a management of hydrocephalus. And with the past few decades, with the technological advancement, there was a sort of considerable minimization of the risk of the procedure associated with the procedure itself, the endoscopic procedure. Still, as the practice grows with every center, they face the challenges and the issues of the patient selection, the criteria, and the clinical and radiographic markers of success. And there's often sort of a controversy or debate about these issues. And therefore, literature would discuss the patient selection criteria, the prognosis, and the predictive factors. So no talk about endoscopic third ventriculostomy would not mention the landmark papers about ETV, and one of them is the benchmark of predictors of success, which is the endoscopic third ventriculostomy in the treatment of hydrocephalus. This was pioneered and championed by Abe Kulkarni and Jim Drake and his colleagues from London and from Tel Aviv. They devised this ETV success score, which is a score that has stood the test of time and was durable to act as a preoperative predictive model, and it helps with the parent and the patient counseling whenever we are, considering the endoscopic option for the treatment of hydrocephalus. In this paper, they had a total of 618 patients with ETV done at their respective centers, and they randomly divided them into a training set to come up with the factors that predicted the success, which were namely the age, etiology, and the previous shunt, and then coming up through statistical methods with the weight for each factor, and then the validation set, which confirmed the durability or the predictive power of this model. But in the prediction, they found that the prediction was very strong, and there was sort of good adherence between the predictive power and the actual success in the patients with a moderate and with the high ETV success score. But with the low ETV success score range, there was sort of a deviation from the actual success. So this was basically because the patients, or there was a small number of patients in the lower score range, and they had a heterogeneous sample with possibly different techniques and equipment from different centers. Also, the cohort was collected over a lengthy period of time, some sort of technical changes in the technique itself that might cause the difference in the success in terms of intraoperative nuances. And they had sort of mixed prospective and retrospective data. So they had a follow-up publication in the following year, the same group, and they addressed this points of concerns in the previous publication, and they got an international cohort from 12 different centers, summing up 1,209 patients, an ETV cohort and the shunt cohort extracted from other previous trials, so this was still retrospective, and they stratified them again into the high, moderate, and the low ETV success score. With the Kaplan-Meier analysis, this was really a very interesting finding from them, that you can have a very durable ETV from the start with a success which is fairly higher than the shunt, and durability higher than the shunt, starting from the early post-operative period, and the difference is really marked after 2 years. With the moderate ETV success score range, the initial outcome is better for the shunt than for the ETV. Then at the age of 2 years, there's a switch, and the ETV success score, or the ETV, I'm sorry, becomes a more durable treatment option. And still, we can have, say, a similar outcome or similar follow-up with the low ETV success score, but with the differences in the magnitude of the discrepancy between the shunt and the ETV success. Other groups have managed to evaluate an intraoperative success for ETV or devise an intraoperative predictive model, and they were the group at Cornell, but this was early on, and they pointed out 3 scores mainly for intraoperative assessment with normal third ventricular anatomy, or the scarred or thickened subarachnoid space, and the presence or the absence of pulsations of the third ventricle at floor after the ETV. With the higher the score, the lower the success, and this is just the opposite of the ETV success score. So whenever we're undertaking an ETV strategy, there is something that we have to, or an ETV practice in the management of hydrocephalus, there is something we need to put in mind. And this was really a note by William Osler. This was his farewell speech to the Boston and the New York medical students. His advice was to begin early, to make a threefold category: clear cases, doubtful cases, and mistakes, and learn to play the game fair. No self-deception, no shrinking from the truth, and mercy and consideration for the other man, but none for yourself, and upon whom you should keep an incessant watch. And it's only by getting your cases grouped this way you can make any real progress in your education, and only this way you can gain wisdom with experience. So lessons learned from this is to categorize your patients into clear cases, doubtful cases, and mistakes. Get very objective and stringent assessment. Collect all the cases, no dropouts. Do reflections periodically and self-assessment. And this is how you can do some sort of the experiential learning activity. And this is why, because we are knowledge workers. We are high-performance knowledge workers who, as medical professionals, we just engage in non-routine problem-solving activity. And every day we face problems with patients and diagnostic thought process that we need to solve through a metacognition. The metacognition is something that we achieving through the identification of gaps in our knowledge or our experience, through the objective self-assessment and the constructive reflection. And we should take necessary steps if we find any gaps or any defects to remedy the identified deficiencies. And this is the basis of the experiential learning, as I said, which is learning from experience. But the experiential learners are not knowledge consumers. They still produce knowledge through their generation of new insights while analyzing their own experience. And this will result in the transformation of experience from just a collection of data to synthesis of new hypotheses, theories, and workarounds to assess or to address deficiencies. So without the philosophy part, we adopted this idea or this concept at Ain Shams University at our center when we started to do revive the ETV as a treatment modality for hydrocephalus. And we did a threefold ETV registry with expanding endoscopic practice from starting 2015 till 2020. And these are just, the cases that I started to collect after my fellowship training. And there we had the central hospital at Ain Shams University with 64 total endoscopic cases, and another procedures in satellites or 2 registries and other satellites at 46 and 19. We did sort of periodic self-assessment. So we started with getting the basic statistics after 24 months out of the registry, with 42 cases of endoscopic procedures and 32 ETVs and 6 tumors with endoscopic management and complex hydrocephalus with septostomies and fenestrations. Most of them were having a subacute presentation, and the predominant radiological finding was aqueduct stenosis. The presentation was mainly divergent macrocephaly or delay in the milestones because they were in an predominantly infantile population, and our mean ETV success score was 60, and this falls in the moderate range. With a mean follow-up of, for those with meaningful follow-up, we had 28 patients, a follow-up of 7.6 months. Some things that we've identified as gaps in our experience or defects and deficiencies is the mortality, which was something remarkable. Basically, the operative causes. One of them died from neurogenic pulmonary edema, and one from vascular injuries. And this was very early on from the first 10 cases we did as ETV there as independent practitioner. And we noticed a child with a void gain, but going to the prime objective, which is the success, we had a 61% success rate over the period of follow-up. 3 out of the failures had a redo ETV, and it was successful in one, so we could collectively have a final 64.4% success for the ETV, and the mean failure time was within the first 3 months. We defined success as longevity of the ETV without the need for another form of CSF diversion in the absence of any clinical manifestations of hydrocephalus. Then we repeated this assessment 35 months after out in the registry, adding more patients in each category, and the aqueduct stenosis was still standing as the most common radiological diagnosis, with still the mean ETV success score falling in the moderate range and having a 60% or the total final 62% success rate, and still getting in the range of 2.6 to 3 months. And this was repeated, I'm sorry. So we had some comparable results to the international figures, but we felt more can be done because mainly we had concerns of the high operative mortality, which deserves definitely attention, and revisiting the procedure, whether technicality and the indication, and what really defines the scar prepontine interval, dense adhesions. How can we just quantify this? Because still this is subjective, or sometimes it's intersubjective. What if the membranes in the prepontine cistern were pulsating, but not the flow of the third ventricle? Will this count in the intraoperative assessment or the score? So these were still things that maybe a growing registry or addition of data would help us discern. Another landmark paper is the paper that came up about 2 years ago. It's the results, the 5-year follow-up of the International Infant and Hydrocephalus Study, because this is something that really concerns pediatric neurosurgeons and parents, is that patients who undergo ETV, oftentimes they don't experience this ventricular drainage and ventricular drop down in the volume as compared to the shunted individuals or the shunted children. And this may raise the issue of the cognitive assessment and the developmental delay possibly. But in there, the group at this international cohort study, they were intending to answer this, having more infants and children younger than 24 months with symptomatic triventricular hydrocephalus, mainly aqueduct stenosis, and they presented their 5-year outcomes in terms of the the HUI score, which is the health of developmental score, and I'm not sure and the HOQ in an overall score as well, but they found all scores for the development and the cognitive assessment for the children were similar, and there were no significant differences between the 5-year scores, subscores with their cognitive, social, and physical and developmental measures between the two groups. So they coined this as the first prospective direct comparison of long-term outcomes of ETV and shunt for infantile hydrocephalus, and they suggest that the overall health status and the quality of life of this cohort of infants in aqueduct stenosis is very comparable between the ETV and the shunts. But the pattern of hydrocephalus in the developing countries is really somehow different. And we're also having a parallel hydrocephalus registry or pediatric hydrocephalus registry, going also synchronous with the ETV registry. And this has pointed out that we have different patient population. Data from the developing countries project an increasing time trends in the occurrence of congenital hydrocephalus, but still, what's really prevalent and reported by Benjamin Worf in East African countries that still infantile hydrocephalus due to high birth rates and high incidence of hydrocephalus secondary to neonatal infections is on the rise. And we can find that the Chiari type 2 associated or the spina bifida associated hydrocephalus and the post-infectious hydrocephalus are amounting for more than 50% of the patients that we're dealing with at our institutions at Egypt, being a low middle income country. And the previously available treatment for these children was the placement of ventricular peritoneal shunt, but there is a financial burden of purchasing the shunt, either on the healthcare cost or directly from the patients if they're paying out of pocket. And more importantly, in shunt-dependent patients, there's some sort of an increasing risk, as this is popularized or advocated by Benjamin Worf and his colleagues, that the longer the shunt in place, the risk, the added risk or the cumulative risk over the years would be substantial. And that sometimes they may have obstructed shunt with acute hydrocephalus and they're in a distant place with limited access to healthcare, to an appropriate healthcare facility, and this may result in grave complications for the patient. So what if something more could be done to improve the outcome, especially in this post-infectious hydro and the spina bifida associated, or the children younger than 1 year? And we are aware that they would have a preoperative prediction according to the ETV success score of less than 50. So, as I said, the champions of the technique, Benjamin Worf and his colleagues in Uganda, and then he also extrapolated this to centers in North America. He combined endoscopic third ventriculostomy or the ETV with choroid plexus cauterization, and there was a rationale for this because it improves the compliance, decreases, acts as a pulse absorber, and also decreases the amount of the CSF that's facing or challenging the subarachnoid space for absorption. But anyway, when he just compared his or analyzed his patients, he found an overall success rate of a combined ETV CPC was 66%, and this was superior to the original 47% in infants younger than 1 year with ETV only. And the increase was mainly robust, or the improvement in the outcome was mainly robust in the spina bifida associated population and not in the post-infectious patients. And then he analyzed another group of patients with myelomeningocele, focusing on them, and he found a 76% success rate with a mean follow-up of 19 months. And most of the treatment failures, which was really he pointed out and stressed upon very frequently, is that most of the treatment failures, or 86% of them, they occurred within the first 6 months and none of them after 10 months. And he coined this as a safe period because of the soft pliable skull, still the retained brain compliance. So manifestations of an obstructed ETV would be noticeable by the parent, and through a divergent macro or a bulging tense anterior fontanelle or irritable kid, and still the urgency of getting a revision of the ETV or putting in a shunt is not as urgent as it is when dealing with a child who is older than 2 years with more rigid skull and acutely increasing intracranial pressure. Then advocates followed who trained in Uganda for a few months or a few years, and then went back to the North American centers that they belonged to originally, and also advocated the technique there in Miami Children's and also in Alabama. They're having big centers, but also in other centers in Africa. They started with Nigeria. So we were also getting a sort of excitement with the technique, and we started our preliminary experience with ETV CPC with an ETV success score preoperatively of 50, and we used a rigid scope, not the flexible scope, and we did bilateral CPC in the lateral visible parts of the choroid plexus and the lateral ventricles with complete cauterization of the visualized choroid plexus. These were at first lengthy procedures lasting for more than 60 minutes, more irrigation fluid, and this may pose idea of the hypothalamus being exposed to irrigation fluid for a long time. We had 2 deaths from acute neurogenic pulmonary edema in the early postoperative period. 2 patients were successful, and 2 patients eventually had ultimately ended up ultimately placing a shunt to around 3.5 months. So these are very discouraging results for us. So we needed to have more attention to the indication, the technical pitfalls and equipment. And the only way to learn this is to go to where it was devised and designed at first, and start with the mindset of implementation of the Cure Hospital experience. So we need to go to the Center for Collaboration, establish a partner treatment location, and at our center, and receive formal training, which helps with the diagnostic thought process, the decision making, the protocol implementation, and technical training as well. So we started by sending one of our colleagues or the young residents who have recently graduated from our neurosurgical program to Ben work for his training at Boston, and then planning to establish sort of satellite to the Cure Hospital experience in Egypt. We're working on this in the meantime, but other centers have succeeded us in this, as Nigeria and Zambia and others. And comparing the Nigerian experience to the original Cure Hospital experience, we can find that they had comparable results. Admittedly, the early treatment failure of ETV was higher in Nigeria at first. The first time they adopted the technique, they had a 54% failure rate compared to the 28% failure rate of the Cure Hospital. But the overall shunt freedom at 6 months was really very comparable. And considering that this is a lower volume institute and they're still not as experienced as the original center in Cure Hospital, they have these are very encouraging results, and possibly the explanation for the difference in the early endoscopic outcome possibly could be the surgical technique differences in the decision making, also regarding the patient selection or the intraoperative conversion from ETV to ventricular peritoneal shunt, how to judge an active
5 minutes.
Yes, I just have 1 minute and we'll be finishing. Failure of the ETV and undergo an ETV revision, all these were possibly explanations. And some of the things that we need to put in mind is that the Cure Hospital have devised their own ETV success score, or the predictive model, and it was based on age, etiology, and choroid plexus cauterization. They put a lot of weight on the choroid plexus. And what's the added benefit for this is the less shunt-dependent children with subsequently less cost of hardware, less instance of late and sometimes life-threatening complications, and it just became a more durable treatment. And also they analyzed their patients and found that there was a similar volumetric analysis and similar cognitive outcome between the shunted patients and also the patients who undergone ETV and CPC. So this is the Cure protocol. It still has ETV in it alone, but whenever there is sort of an aqueduct which is closed and a cistern which is a little bit not that scarred, so they would proceed with an ETV CPC whenever there is a higher likelihood of failure of an ETV alone. And also dealing with a failed ETV, they can also add either do a VP shunt if there is cisternal scarring originally and this was mistaken or overlooked, or do another repeat ventriculoscopy to assess the ETV, or add the CPC whenever it was not added. So I'm really thankful for your time, and I'm open for any questions. Thank you.